Vamos a ver qué tal. ¿Qué tal? Bien, muy trabajado, pero bueno. Ya me ha dicho Leo que el paper lo habéis mandado a los meses. Es importante que se ha hecho en los últimos años.
Que no, pero si lo ha propuesto ella. Good afternoon. A ver, no sé. Ok, vale. Okay, good afternoon, everybody. It's a great pleasure to be here, sharing this time with all of you. Thank you so much for being already at the meeting, the first day. I know many of you have worked a lot of hours this morning, so thank you very much. I am sure we will enjoy with our speakers and also with the discussion. I feel really proud of chairing this first symposium about public health and aging. Our goal is to address the public health approach in the context of the current demographic changes. The symposium will be composed by 3 talks, 25 minutes each, with 15 minutes for discussion. First, Dr. Rodríguez Artalejo will talk about the theoretical framework. In second place, Dr. Asumi will explain the World Health Organization perspective. And lastly, Dr. Andradas will talk about the national perspective. So go on. The first one, Fernando Artalejo, is the first presenter today. He is professor and chairman of the Department of Preventive Medicine and Public Health at the Universidad Autónoma de Madrid. He also leads a group devoted to research on cardiovascular and nutritional epidemiology in older people within the Cyber of Epidemiology and Public Health, which is funded by the Instituto de Salud Carlos III. His talk is entitled Public Health in an Aged World. Sí, yo creo que sí. Te hago un signo.
Good afternoon. I would like to start by thanking the organizing committee of this meeting, and particularly Cristina Alonso, for her very kind invitation to be here with all of you. And I promise not to be good, but to be brief, which is just a good idea in any presentation. Let me just present the 2 main objectives of this presentation. First, I would like to summarize in just 2 slides. This is a very difficult task, but I will use only 2 slides to summarize the health status of the Spanish population. And in this slide, there will be both good and bad news. And we'll try to comment about those news, and also to examine the role of population aging on the health status of the population of Spain. And once examining the role of population aging, I will try to propose what will be the main challenge for public health in Spain over the next year. And this challenge, and all of you may guess, is to promote healthy aging. And the second, once that we have cleared the main objective, I will comment a little bit on how to do it. And the road to healthy aging is the prevention and management of frailty and disability. And I will try to explain why and how to do it. So let me show you the first slide. This slide presents the trends in the rate. Please pay attention to the rate of the years lived with disability among those aged 70 years and over in Spain. And as you can see, the trend is relatively flat, but with some tendency to decrease. In 1990, the rate was 24.5 per 100,000 people. And in 2016, the rate was slightly lower. So I would say that the news are fairly good. The rate in years lived with disability in Spain has been flat, but perhaps even decreasing over the last decades. This data has been taken from the very well-known Global Burden of Disease study. And now, let me show not the rate, but the number of years lived with disability. And as you could see here, well, this is the rate, this is the number, and the tendency, the trend is completely different. There is a very steep increase in the number of years lived with disability in Spain. These are the bad news. What news do you think are worse or are better? Do you think it's more important, the good news or the bad news? The bad news are more important because of two reasons. The first one, because they are bad. And the second, because the rate is only important for epidemiologists and health researchers, because they only serve to understand the behavior of the determinants of the rate, to understand the evolution, the trends of the risk factors of disability. But the absolute number clearly represents a measure of the absolute needs of healthcare and social services in the Spanish population, and the needs has been progressively increasing. And what is the reason for these divergent trends? Population aging. Let me show very briefly how the Spanish population has been changing over the last decades. This is the pyramid of the population structure in 1990. This is for 2006 and 2016. These are data taken from the National Statistics Office of Spain. And in my view, there are two main issues in this pyramid. The first issue is look at 1990 for the people below the age of 20. As you can see, each subsequent generation is smaller than the generation before because of a decreasing birth rate. But this problem has been accentuated over the last decade, so that from the age of 50 or 45, each subsequent generation is smaller or only similar to the preceding one. This is translated into an increasing percentage of older people in the Spanish population. Not absolute number, simply percentage, a higher percentage of older people in Spain. And the second important phenomenon relates to the length of these bars. Bars corresponding to the people over the age of 50. When we compare the length of this bar in 1990 and the length of the same bar in the year 2016, there is an absolute increase in the bar, which corresponds to an absolute increase in the number of elderly people in Spain. So, for population, and this trend will progressively increase over the next decades according to the projections of the National Statistics Office. So, when we talk about population aging, we are referring to two different and distinct phenomena. One is the increase in the absolute number of elderly people, and the other one is the increase in the percentage of elderly people. And they have different consequences, different implications, and they should be approached differently. For instance, when we talk about the number of people over the age 65 in Spain in the year 2016, we have about 2,600,000 people over this age, and the projections suggest that there will be over 11.5 million of people over the age of 65 in the year 2013. What are the main, not only health, but also social implications? An absolute increase in the number of healthcare and social needs in the Spanish population. And there are only two simple approaches to manage it. One is to increase the resources devoted to pay for these healthcare needs. And the only way to do it is by increasing the economic resources in our country, by improving the state of our economy. But the other approach is to reduce the needs. And here is a place for healthy aging. And the second phenomenon is the increase in the percentage of people over 65. Currently, we have about 29% of people over this age. We expect to have about 40% people over this age in a few decades. In fact, Spain is one of the countries in the world with a higher percentage of people over the age of 65. One of the countries in the world with the highest percentage. And the main implications is that there will be a lower percentage of people in the population who will have to pay for it, because there will be less people below the age of 65 and more people who will not be economically active and will not be able to pay for it for these healthcare and social needs. What is the main approach to it? Well, given that there will be no much more people, we need to increase our economic productivity. In fact, one of the main problems of the Spanish economy is that we have a very low productivity, which is clearly linked to the educational level of the Spanish workforce. Second, we have to reduce unemployment, so much more people could enter the marketplace. Third, we should increase the birth rate and to increase immigration. None of these policies are easy. It's much more easy to talk about them than to perform the appropriate structural modifications in our country to attend, or to improve economic productivity, to reduce unemployment, and so on. But finally, retirement age should inevitably be extended. And to do it, we need more healthy people over the age of 65. So healthy aging will be at the center of all public but also social policies in our country for the years to come. Well, if we should pursue healthy aging, why should we focus specifically on disability? There are both practical and conceptual reasons to do it. Well, here again we have the trend in the disability rate in Spain. You already know this figure. But here you have the rate in mortality in people over the age 70 in Spain. As you can see, the mortality gains have been much greater than the disability gains. We have been able to reduce the mortality rate much more than the disability rate. So there is much more room to improve the disability rate in Spain. In fact, our mortality rates are exceptionally good. This is why we have one of the longest life expectancies in the world. So the problem is not with mortality rates, it's with the disability rates. And second, because disability is at the core of the concept of healthy aging. This is a conceptual reason. There is a very nice comment published a few weeks ago in BMC Medicine by Alarcos Fieza, a Spanish woman who is working in WHO, also by Sobna Chatter, he's also working in WHO, Jerome Bickenham, a Swiss researcher, and Carla Sabariego, who's also working in this field. And they emphasize the idea that disability represents the non-fatal impact of health conditions. We have been able to control the fatal impact of health conditions by reducing mortality, but not the fatal impact of health conditions, because we have not been able to reduce disability to the same extent. Second, disability is not a yes-no variable, it's a continuum variable. And most people, I would say all people, is either currently experiencing disability, some level of disability, or is vulnerable to disability over the course of their lives. And finally, disability is a mirror image of healthy aging. In fact, according to the WHO definition of healthy aging, it is a process of developing and maintaining the functional ability. And functional ability comprises all health-related attributes that enable people to be, and moreover, to do what they have reason to value, everything that matters to them. According to this conceptual framework of healthy aging and functional capacity results from two main variables, and in particular the interaction of these two variables. One is intrinsic capacity, and the other one is the environment. Now, you shouldn't be surprised that intrinsic capacity is very closely linked to the concept of frailty, also according to the definition of the WHO. So the focus should be placed, for both conceptual reasons and practical reasons, on prevention and management of frailty and disability. And there are many, many ways to measure frailty and intrinsic capacity, but there has been a very interesting publication by Matteo Cesari, John Bird, Bruno Velas, and other researchers in the Journal of Gerontology, proposing the main components of intrinsic capacity. All of them are very closely related to the concept of frailty, but they specifically added the function of the sensory organs, also another psychological dimensions, but all of the other components are strictly and very closely related to the concept of frailty. Well, what are the main causes of disability? Well, this is well known by all of you, and also by the market. The first one in the world, this is Spanish. In the Spanish population over the age of 70 years. The first one is age-related hearing loss. And everybody knows it, particularly the market. If you have a look at Barcelona or Madrid, the type of shops and retailers more frequent are cafeterias, bars, and restaurants. Then you have hairstylists. And the third place you will see shops selling hearing aids. We have it even in large malls, in supermarkets. So people is reacted to it, but I am afraid that the health authorities do not have these ideas as clear as the market. You also have Alzheimer's disease, low back pain, falls, and obviously diabetes. But the problem is that what we know about the risk factors of these entities is very little. And just to show you an example, also using data from the Global Burden of Disease database, I have focused on the known risk factors for low back pain. Low back pain, just a symptom, which is the third cause of years lived with disability. These are the main well-known risk factors for low back pain: high BMI, smoking, and occupational and ergonomic factors. Well, the known risk factors of low back pain only explain less than 2% of all cases of low back pain in the population, which can be easily obtained by examining the attributable risks, who also appear in this slide. Less than 2% of all years lived with disability in the Spanish population. So, to summarize, public health should focus on prevention of disability, but the main drawback is that what we know about the main risk factors of disability, and perhaps also of frailty, is still very little. Over the last years, in collaboration with my friend Leocadio Rodriguez Mañas and other researchers, we also agree with these people from WHO in that disability as a health outcome deserves much more attention than it has so far received. And this is why we decided to start working in this field. And we have produced a number of papers increasingly which were still published in this area, which have served us to produce a sort of conceptual framework of what are the main risk factors of frailty and disability. Obviously, we start by acknowledging the role of chronic diseases on frailty and disability. We also believe that in a few number of cases of frailty and disability, the only identifiable cause could be simply aging, in a few number of the cases. But what we have also taken into account has been the traditional health determinants, as proposed by Lalonde and Laframboise, because they serve as a very good framework to organize research in this area. These are health behaviors. And we have produced, in collaboration with our researchers, very good information about the role of low physical activity, sedentariness, poor diet, and alcohol intake on the risk of frailty and disability. There are also a role which is clearly understudied for environmental risk factors. We have been starting to study the role of lead, calmants, environmental tobacco smoking. Here, this line of research has been led by Esther García Esquina in our group. We have also started to assess the role of healthcare factors, in particular polypharmacy, oral antidiabetics, nutritional advice. And to make this story short, we have also examined the role of several mediators, including omic mediators within the omic studies, so that we, in collaboration with many other people, are starting to know much better the determinants of frailty and disability. And I think one of the priorities for public health in the next year should be to focus and to promote research in this specific area. As a conclusion, we have already surpassed the era of disease-based medicine and public health to enter the era of medicine, and specifically in this case, public health based on function. Second, disability as a health outcome deserves much more attention than it has so far received. But the good news is that according to many works published in the literature, many of the main risk factors for diseases are also the risk factors for frailty and disability. So that with a very broad public health approach, which still keeps attention on morbidity, but refocus interventions to prevent frailty and disability, we have the hope that this problem could be managed in the future. Thank you so much. It's really a pleasure.
Okay. Thank you very much, Professor, for your amazing talk. I think you have focused really well the topic for the next speaker. The next speaker is Yuka Sumi. She has joined to the World Health Organization, concretely in the Department of Aging and Life course since December 2016, as a secondment from the Kanagawa Prefectural Government from Japan. She has led on the establishment of clinical consortium of healthy aging, which goal is the development of standards and guidelines on the clinical aspects of healthy aging. She is going to tell us more about her work in the next talk entitled Global Strategy and Action Plan on Aging and Health, the WHO Clinical Consortium on Healthy Aging.
Hi, everyone. My name is Yukasumi from Aging and Department. Okay. My name is Yukasumi from Aging and Life Course Department in World Health Organization in Switzerland. I would like to thank Dr. Alvaro Casas and Dr. Cristina Alonso and the organizers of this 8th National Meeting of the Spanish Society of Geriatric Medicine to give me this opportunity. Today, I'd like to talk about the integrated care for older people and WHO Clinical Consortium on Healthy Aging. Populations around the world are rapidly aging, with some of the fastest change occurring in lower and middle-income countries. Global Strategy and Action Plan on Aging and Health was adopted in 2016 by the 69th World Health Assembly. The strategy restates WHO's commitment to building the world where adults will live not only longer, but also healthier. And this strategy focuses on 5 strategic objectives: commitment to action on healthy aging in every country, developing age-friendly environments, aligning health systems to the needs of older populations, developing sustainable and equitable systems for long-term care, and improving measurement, monitoring, and research for healthy aging. Integrated Care for Older People, ICOP, and the WHO Clinical Consortium on Healthy Aging I will talk about today are mostly for the Objective 3, aligning health systems to the needs of older populations. This February, a user-friendly version of Global Strategy and Action Plan was released. This new publication also includes a list of 10 indicators that was selected to measure progress in the implementation of the strategy. This is a significant step forward in establishing a framework to achieve healthy aging for all. So what is healthy aging? Already Dr. Artarja explained, sorry, I hope the pronunciation is okay. Yes. Yep. Explained. In 2015, WHO launched the World Report on Aging and Health, which defined that healthy aging focuses on the goal of maintaining functional ability across life course. Functional ability is the interaction of intrinsic capacity of the individual and the environment, all the factors in the extrinsic world that forms the context of the individual's life. WHO defines intrinsic capacity as a combination of individuals' physical capacity and mental capacity. Let's say my visual acuity is 0.05. It's really very, very bad, and which is my intrinsic capacity. But now I'm wearing the contact lenses or with glasses. My functional ability on vision is fine. That is the difference between intrinsic capacity and functional ability. Functional ability is anything environment can help to have a function. So within any population of older age, many individuals will experience periods of high and stable capacity, declining capacity, and a significant loss of capacity. And each of these three periods requires different responses to be emphasized. For the people who has a high and stable capacity, health systems need to prevent, detect, and control disease and risk early. And for the people with declining capacity, health services are needed to help stop and slow declinings in intrinsic capacity. And for the population with significant loss of capacity, the provision of long-term care is needed. Intervening on earlier stage is essential because the progress of becoming frail and care-dependent can be delayed, slowed, or reverted if we target earlier enough in the process of functional decline. Therefore, this middle stage is very important. The focus is maintaining function across the life course and enabling a person-centered integrated care by shifting from detecting diseases in one point in time and treating in fragmented ways to assess function longitudinally across the life course. Healthy aging considers all the phases of older people as part of a continuous trajectory of ability and capacity. The public health intervention should be seamless to remain relevant for all the older people as they transition from one phase to another. The first circle is where the traditional health system tends to focus, looking to acute conditions and treat them, using a finding and fixing approach. This last part of the curve is where the geriatricians tend to focus, and they are interested in issues such as frailty, urinary incontinence, falls, and care dependence. What we realized is a very neglected area, that is the middle of this curve, in terms of how we frame our response. And what we know is that traditional services are not going to meet the needs of these people. What we need is a person-centered integrated care. As people age, their intrinsic capacity becomes more chronic and complex. Multimorbidity is increasingly prevalent with age. The health and social needs of aging populations are typically complex and long-term. There are limitations of traditional models of care. Older people are frequently faced with numerous healthcare workers may be involved with one person's care. They go to 6 doctors every day. Yet, many existing health systems manage health issues in a very fragmented way. There is a lack of coordination across care providers and settings, which may lead to polypharmacy. The healthcare and social care are typically fragmented from each other. Older people find it difficult to use services even when they are available. 60% of older people in low-income countries do not access health care because of the cost of the visit, the absence of transportation, and the inability to pay for transportation. And then, when they manage to access services, they encounter negative attitudes of healthcare providers. declining in intrinsic capacity is expressed very frequently as common impairment. For example, I cannot hear well, I cannot see well, or I cannot walk as I used to, or I forget things more often. And this is very common impairments. And early markers of declining intrinsic capacity, such as decreased gait speed or reduced muscle strength, are often not identified, treated, or monitored. These problems are often overlooked and interpreted as a sign of normal aging. And oh, don't worry, you are getting old. It's a natural thing. But you think about it. If they can be reversed or delayed, it's very crucial to identify. And the majority of health professionals lack guidance or training to recognize and manage impairments in older age. I know I was a primary care physician. I had no clue how to treat these impairments in older age. I didn't have any education how to treat these older people without any disease diagnosis. And there is a lack of guidance on interventions to optimize intrinsic capacity and functional ability. Health professionals in clinical settings would need to be able to detect declining in intrinsic capacity and deliver effective interventions to prevent and slow its progression towards negative outcomes associated with care dependency in older age. These all four factors can lead to older people disengaging from services, not adhering to treatment, or not going to primary health care clinic based on the belief there is nothing they can do. There is nothing the healthcare professionals provide. There is a pressing need to develop comprehensive community-based approaches and introduce interventions to prevent decline in capacity and to provide support to family caregivers. WHO has launched guidelines on community-level interventions to manage declines in intrinsic capacity. In last October 2017, the objective of these guidelines is to prevent care dependence in older age. These guidelines would assist healthcare professionals and people who support older persons in community settings to detect declines in physical and mental capacities and to deliver comprehensive and integrated care to prevent and delay progression. 13 recommendations contained in these guidelines were reached by consensus of a guideline development and review group convened by WHO that included more than 100 experts from 85 countries. So how this could be done? These guidelines offer evidence-based recommendations on 6 areas for actions: improve musculoskeletal function, mobility, and vitality, maintain older adults' capacity to see and hear, prevent cognitive impairment, promote psychological well-being, manage age-related conditions such as urinary incontinence, prevent falls, and support caregivers. These actions will optimize older people's physical and mental capacities and enable older people to participate in and contribute to society for a longer time. There is a Spanish brochure available on the WHO website. If you look inside the brochure, you will see the 13 specific recommendations and the 6 actions. So here are the key principles of integrated care. We need to design coordinated health and social services, offer services closer to where people live, assess older persons' needs and physical and mental capacities as comprehensive assessment, and define the goal of care and develop a care plan with multi-component interventions. The assessment and care plan needs to be shared with everyone involved and enable all professionals, such as community health workers, family doctors, social workers, to work together towards a single goal, that is to maintain intrinsic capacity and functional ability. Engage communities and support family caregivers. In the WHO ICOP approach, healthcare workers identify older people in the community with declines in intrinsic capacity as a rapid case finding. Those people with declines are referred to comprehensive assessment, not only disease assessment, but the focus should be on intrinsic capacity, functional ability, and social care needs. And then, the multidisciplinary healthcare team should design a care plan in partnership with older persons and caregivers, and taking account, which is very important, into the older person's needs and preferences and goals, and then prioritize interventions to support them together with the older person themselves and caregiver. Multi-component interventions recommended in ICOP guidelines should be delivered, such as strength and resistance exercise, oral supplemental nutrition, home adaptation to prevent falls, and cognitive stimulation. WHO has established a solid relationship with International Association of Gerontology and Geriatrics Global Aging and Research Network, IAGG-GAN, and the European Society for Clinical and Economic Aspects of Osteoporosis, Osteoarthritis, and Musculoskeletal Disease, SKO, to discuss the operationalization of intrinsic capacity concept and determine the processes leading to frailty. Building on these existing collaborations and the work, in 2017, Clinical Consortium on Healthy Aging has been proposed to advance research and to contribute to the development of standards and guidelines on the clinical aspects of healthy aging. There are several members in this room too. The scope of the clinical consortium is driven with the necessity to change current models of care to more comprehensive and integrated approach, focused on the maintenance of intrinsic capacity and functional ability. And 4 work streams in Clinical Consortium on Healthy Aging has been proposed. First, develop a WHO intrinsic capacity assessment to be used in the context of comprehensive assessment of the health and social care needs of older people in primary care settings. Second, harmonize clinical data across research, and conduct our international study of ICOP pilots and implementation. And the last, Healthy Aging Academy, which can contribute to the capacity building of health professionals and clinicians on healthy aging aspect. The core of consultative clinical consortium meeting last year was finding ways to operationalize the concept of intrinsic capacity. In other words, to make it work in clinical practice. The group agreed that the most important priority was to build an instrument to assess each domain of intrinsic capacity. This paper was already introduced. 5 domains in intrinsic capacity are locomotion, vitality, sensory, cognition, and psychological function. And the evidence of these domains was published in this paper. And it is very important to acknowledge that these 5 domains of intrinsic capacity should not be considered as a standalone silos. In fact, each domain interacts with others. To translate these steps into practice, it is necessary that validated measures for adequately capturing each intrinsic capacity will be identified. So within the 5 domains, the clinical consortium aimed to identify measures of intrinsic capacity that could reliably capture information across the 3 periods of intrinsic capacity: robust, declining, and significant loss of capacity, and can be compared across these different levels and across different settings, and amenable to continuous monitoring as well as diagnostic assessment. The utility of this intrinsic capacity assessment tool is shown here. Measurement of intrinsic capacity should be the first step in the evaluation of older people. The combination of intrinsic capacity brief assessment and the routine clinical assessment such as chronic disease, diabetes control, everything would be used to create a comprehensive care plan. Intrinsic capacity assessment tool needs to be feasible, simple, and acceptable in different settings, including low-income countries. And it should be tied up with care pathways that indicate actions. And it can be used by non-specialized health workers in community settings. There are not many geriatricians all over the world, so we need to think how it can be adapted by non-specialized health workers, not necessarily doctors, could be nurses and social care workers. And also it can be applicable for self-assessment by older people themselves and caregivers, because it can be considered in the context of the advancement of technology. Because, for example, multi-devices, wearable devices, or smartphones are able to automatically capture a wide range of data about the function. And the assessment of intrinsic capacity should be ongoing, not one-off, and should be used for monitoring across whole trajectory of life course. And this task is extremely challenging, given the need to find among the multiple available instruments the most validated and accepted tools that can be applied worldwide. So we have established the small working group for this intrinsic capacity assessment tool in clinical consortium. Leo and Matteo are the members. And the group is scoping which items and tests should be used to assess intrinsic capacity to identify older people in the community with decline in intrinsic capacity who are in need of more in-depth assessment. And there are many points of consideration for this assessment. Ideally, measures should take no more than 5 minutes, and simple and objective, and be used by non-specialized health workers in low-income countries. And as you can see, I said in progress. Yes, there are so many discussions now, are still underway. So what we are planning to move forward to implement integrated care for older people at the clinical level, we are developing ICOP handbook for healthcare professionals on comprehensive assessment and care pathways for older people. And IC assessment tool, now clinical consortium working group is working on, is essential to diagnose and monitor intrinsic capacity, as well as to measure the outcome. At the system level, we are developing a guidance for health systems on how to develop and monitor and evaluate services in member states in ways that can support integrated care for older people. We call it ICOP Country Toolkit. And later, we are aiming to pilot and clinical validation study of ICOP approach in various settings. I would like to finish my talk introducing WHO's 13th General Program of Work from 2019 to 2023, which will be considered to get approval in 71st World Health Assembly next month. With the Global Strategy and Action Plan on Aging and Health, WHO targets to reduce the number of older people who are care dependent from 18 million to 15 million by 2025. This is our team in Aging and Life Course Department. Thank you very much for your kind attention.
Okay. Yuka Suma has clearly explained what WHO is doing to promoting the healthy aging. Our last speaker, Elena Andradas Aragonés, is the current Director of Public Health Quality and Innovation within the Ministry of Health, Social Services and Equality. Previously, she was Director of Research Area and Healthy Studies within the Pedro Lain Entralgo Agency, Deputy Director of Quality Research and Teaching in the SESCAM, and Deputy Director of Health Promotion and Epidemiology within our Health Ministry. Her talk today is about a strategy for health promotion in the Spanish health system, document on the prevention of frailty and falls in the elderly.
¿Me vas a ayudar tú? Sí.
¿Cuál era?
Esta.
¿Este?
Creo que sí, creo que era esta.
¿Es correcto?
Sí. Muy buenas tardes. Me han pedido que presente en inglés y voy a intentar hacer la presentación en inglés. Good afternoon. I want to thank the organizer of this event because, I'm very pleased to be here with all of you, and thanks to the Sociedad Española de Geriatría, Medicina Geriátrica, to be so kind with me, with the Minister of Health, Social Services and Equality, to be here with all of you. I would like to present the consensus reached at a national level in our national health system in Spain related to frailty prevention. But sometimes when, okay, I'll try, yeah. Sometimes when you are the last speaker, it means that some ideas, some indicators have already been presented. And I'll try not to repeat again the same idea, but complement the ideas already presented. I think we don't have any doubt about the greatest achievement of our society, which is reflecting in the high life expectancy in our population in Spain. But in this, as Dr. Fernando Rodríguez Artalejo has already presented, this is our demographic pyramid that represents the population right now in Spain, but the forecast for the next years. And now in Spain, in 2016, more or less, we have a huge. We think that we are going. The prediction shows that we are going to have a huge change in the number of the percentage of the population aged 64 and over. In Spain, we estimate that 35% of the population will be over 64 years old in 2066. And moreover, the segment of the population that increases more is the one greater than 80 years old, going from 3 million people in 2016 to more than 7 million people in 2066. Our country, as has already been presented, has one of the highest life expectancy rates in the world. However, other neighboring countries are ahead of us in terms of healthy life expectancy. And good health is one of the pillars of a socially, economically thriving society. In this slide, you can see that healthy life expectancy is increasing in our country too. But this is not enough to overcome the existing gap with life expectancy, both in men and in women. And this gap means men will live on average of 12 years in poor health, while in the case of women, the figure is 20 years. This is according to our national statistics. And if we focus on the population from 65 years of age, we see how not all of the years of life expectancy gain are lived in good health. This situation is especially worrying for women, in which practically, as you can see in this slide, half of the life expectancy at 65 years of age is lived with some kind of disability. And according to the latest European Health Survey in Spain, this survey was made in 2014. 58% of women and 44% of men aged 65 and over declare limitations to be able to carry out our activities of daily living, such as cooking or dressing. That means that our real challenge is to maintain the autonomy and independence as people age. And as you can see in this slide, well, this is based on the recommendation on the Public Health Framework for Healthy Aging recommendation of WHO. And as you can see, when people have this high and stable capacity, the aim of health services should be, as Yuka has already said, to prevent chronic disease conditions and control them. But in the next stage, in the stage of declining capacity, the focus should be on the reverse or slow this decline. The health of the elderly must be focused in terms of function instead of disease. Because function determines the life expectancy, the quality of life, and of course, the resources or support that each population will need depends on the functionality of people. And the functional situation is right now one of the best predictors, not only of mortality, but also of the incident disability instead of disease. And in this context, is in which frailty becomes important, since it is potentially reversible. The main interventions that have proved effective in preventing and even reverse the state of frailty are physical exercise and multidimensional geriatric assessment, followed by intervention on the main geriatric syndromes with emphasis on nutritional status, hydration, and medication review. With the aim of gaining years of life in good health, in December of 2013, the Spanish strategy of health promotion and prevention in the National Health System of Spain was approved in the Interterritorial Council. For UCA, our Interterritorial Council, UCA, is the place where is the body where the Minister of Health of Spain with all the regional Minister of Health make decisions related to our national health system. And this strategy was developed using a participatory method based on the evaluation of good practices in promotion and prevention. And this strategy, we look at this strategy as an opportunity to integrate and coordinate all the efforts of health promotion and prevention among all levels, institutions, sectors, and actors involved, because society gives a high value to health and demands a joint, a coordinated and integrated response of effective intervention for them. In this strategy, in the strategy of health promotion and prevention of our national health system, we address the promotion of a healthy lifestyle in a comprehensive way, emphasizing the intersectorial work as well as equity. And this integral approach involves the joint consideration of the main risk factor for chronic diseases. Healthy eating, as you can see, healthy eating, physical activity, alcohol risk consumption, tobacco consumption, and emotional well-being. Our perspective is that this factor interact, producing an effect superior to the sum of this individual effect of each of them. That means that to have a greater impact it's important to address all these determinants in an integral way in order to have a greater outcome. This slide represents the implementation plan of this strategy since its approval in 2013. But I think instead of explaining right now all the actions, I think it's better to go directly to this is one of them. This is one of the activities that has been developed. This is a website on promotion of healthy lifestyles with information and training resources for the general population. The purpose of this website is to provide us a useful and reliable health information adjusted to the different needs of citizens regarding the different risk factors. And frailty and falls prevention is one of these one priority of this strategy. The Ministry of Health, Social Services and Equality, together with all the representatives for all the autonomous communities, and of course, including all the scientific societies of primary care, medicine and nursing, along with geriatrics, reached a consensus in 2014 for the Spanish national health system on the prevention and frailty and falls in the elderly. The purpose of this consensus is the early detection and intervention on frailty and or those with high risk of falls as a tool to gain health and to prevent disability. The consensus establishes the minimum common components to be implemented throughout the primary healthcare system based on the algorithm that you can see here in this slide. I don't want to go in depth in the algorithm, but at the end, applying the algorithm, we are able to classify people as frail. And in this case, these people will be offered a multi-component exercise program, while non-frail autonomous people will be offered a comprehensive advice on healthy lifestyles in primary healthcare centers linked to specific interventions in the community using the community resources. And as we know, in order to reduce frailty, it is necessary to act on its main risk factor, and one of it is inactivity. Interventions that have focused on physical activity have demonstrated the effectiveness of delaying and even reversing symptoms of both frailty and disability. Physical activity has also been proved to be effective for improving cognitive status and fostering emotional well-being. If, in addition, interventions are group-based, we have an added benefit of promoting well-being and social networks among the elderly. That's why those classified as frail will receive a multi-component physical exercise program, and this program is developed at a community level with the resources available in place, with 2 or 3 sessions per week for 6 months. The consensus report, the consensus document, includes some basic recommendations for developing a multi-component program aimed at the frail population. And this slide shows an example of the exercises that can be part of this program, strengthening the strength, balance, flexibility, and endurance. And to support the implementation, we have designed a capacity building program for professionals. It has an online interactive methodology, and it has been offered free of charge through the head units of continuous education in all the autonomous communities. The satisfaction level and reception among participants, who are essentially health workers working at the primary health level, has been excellent. And because, has been excellent. We try to focus on primary care level because they are the responsible for implementing the consensus reached at a national health system. The course consists of 7 modules, and it starts, of course, with an initial reflection about the issue, followed by the theoretical contents, including interactive exercises, videos, key ideas, and practical cases. Different chapters are devoted to the frail concept, frailty detection and frailty intervention, focus on how to design and develop a multi-component physical exercise program. And in this slide, you can see one of the screens from this training platform. Right now, currently, the course has completed 4 editions in which more than 5,000 professionals working at a primary care level from all the autonomous communities have been trained. The consensus in the prevention of frailty and falls is progressively being implemented in all our national health system. But at the same time, right now, at this moment, 11 autonomous communities have incorporated at least one part of the consensus in one specific plan. And we try to evaluate the degree of implementations every 2 years. We reached the consensus in 2014, as I told you before. At the same time, in this evaluation, we try to identify the critical points in order to continue with the implementation. And in this case, the difficulties in the last session, the difficulties presented were the registry and the analysis information. That's why this has been addressed on a specific group with professionals, with representatives from different autonomous communities, of course from different societies. And now we have one specific way to register frailty in the local electronic medical record. This is a consensus again for all the community, the autonomous communities. They now know how to register frailty in order to follow the evolution and the interventions that in primary care level are implementing. The next steps will be to advance in the coordination of resources at the local level to develop these multi-component physical activity programs, and of course to go on with the health professional online capacity building programs. And to conclude, here you have an overview of the strategy of the health promotion and prevention strategy, and with some specific initiatives to implement. In general, we work in 3 settings: at a primary healthcare level, as you see, linked with the resources in local and community level, and of course taking into account the educational centers. Why? Because we work in this strategy with this life course perspective, taking into account health promotion and prevention interventions since pregnancy, infants, adolescents, adults, and of course, elderly. And it is early to appreciate, since 2014, it is early to appreciate any change in the trend of healthy life expectancy indicators, but I think that with the work that we are doing, the pillars of promoting healthy aging and well-being have been set. And I really believe that to gain years of life free from disability has to be a major goal for our society. Thanks for your attention.
I would like to thank our speakers, their talks. I think all of them have been really focused. And I don't know if in the audience, do you have any question or some doubts, something to clarify? Any comment? Professor?
Thanks. Thank you all. I would like to ask all of you perhaps. Yuka has talked about the ageism in the healthcare professionals. But I think that ageism is also very frequent in policymakers. And in some way, you are exceptions. But if you go to many public organisms, they absolutely ignore everything about other people. And in some, for instance, I am thinking in high voice, DigiSante. If you go to DigiSante is like the Ministry of Health for Europe. They have eliminated the program about aging. And if you look at the last calls of DigiSante, aging has disappeared. And in some way they have gone step back to a more classical approach to diseases and prevention. The Office of Life Cycle in WHO is 3, 4, 5 years of life. Yes, and you are working there 10 persons? How many people is working in your office? 10 persons, 12 persons? How many people is working in the program of vaccines? Or in the program of things? No, so I am trying to put the things in. And of course, sometimes the speech is not followed by actions. And I would like to know if you have some ideas or some feelings on how to promote. Fernando has shown an editorial about why frailty is out of the field of public health, and this editorial was 3 years ago, or more or less. Some ideas to make that aging or aging programs should be highly represented in the institutions and policymakers. Thank you.
Do you want to answer?
Okay. There are different, well, I don't know if I'm going to be able to answer all the time in English, but I'll try. Okay. You have mentioned, Leocadio, 3 very different levels. The supranational level of WHO. WHO is the organism, the international organism for health, for international health. And if we think about international health status, international health level, maybe the aging is not the first priority in all around the world. But think about the world, the needs and the priorities all around the world. If we talk about, that's why maybe we have approved this plan just in the last assembly, in the last WHO assembly, but most of European member states of course, really agree and have a huge commitment with this plan encouraged by WHO, and we are supporting it. And at the European level, I think something has changed, because in 2012, if you remember, if all of we remember, there was like a huge, a very important initiative related to, I can't remember, EPA. It's like yeah. And now things have been changed in the European Union. I know what you mean. But for us, for Spain, I was working at that time in 2012 in the Ministry of Health, Social Services, and Equality. For us was a very encouraging initiative, because we really think that we have to focus on elderly in our country, not only taking into account how to orient, how to organize our health system, but also in order to have more autonomy and more independence, working with this life course perspective, since working in promotion and health promotion and prevention, as I try to explain just some minutes previously.
You are islands, you are the exceptions in some way. And how is possible to, how you should, I don't know if or I or we can make efforts doing the exceptions the rule. Because you are exceptions. What you are doing is not the rule. This is my personal feeling. And is there any strategy or what can be done to make that this idea of problems of aging here?
Okay, I feel like Leo says we are not doing enough. I get that. Yes, yeah. Because we have. Thank you. Yes. It's true. Our aging department is still new and not get the enough interest from member states yet. But we have a mandate to serve member states, which means countries, member countries, to have a good health policy for older people. And the thing is, the people in the policy are getting there. In high-income countries, they are now scared to have a lot of older people, and because they see it's a burden, which we have to change too. But whatever reason is, they are getting interest. They think we have to do things. And for example, let's say in middle-income countries, they don't have any long-term care system at all as a nation. And they think, oh wow, the population of aging is increasing so fast, even compared to high-income countries. So they come to us. So what should I do? For example, Vietnam, like East Asian countries, they come to us, what kind of policy we should implement. And the thing is, we have established the healthy aging concept in 2015. And for the first time, targeting older people guidelines launched last year. We are still new, but still we are making a progress. And doing that strategy for healthy aging is adapted 2016, and the good thing is that the GPW I mentioned will be adopted this May. So it's very important, WHO as an organization, to show all the member states, you have to work on this. You have to work on these care-dependent older people. We need to decrease these people. And how to do that? We have a mandate to show what kind of norms, what kind of guidelines they can use. Otherwise, they don't have any clue how to do it. And especially clinical consortium is working only on clinical aspects, but for the member states, for the countries, they need to know how to implement in current health system, which we are working with a member states too. So one day, probably in 3 years, 5 years, we will make progress, I promise.
Fernando?
Thank you, Cristina. Well, I agree with Leo, but many people could also think that there are many pathways to Rome. And if you ask people working in the vaccine department, they will say that they are also working for the older people because there are many vaccines, such as influenza vaccines and herpes virus vaccines. In fact, there will be a roundtable on vaccines immediately after this roundtable, that they are also working to to attend the needs of the older people. And if you go to the Department of Chronic Diseases, they will also say that they are particularly interested in integrated care to attend the chronic diseases and to manage the chronic diseases of the older people. So I would say that there is a need to make clear what is the added value of an approach focusing on healthy aging once we have many people working on vaccines, on integrated care, and on many other things. And this needs to be attended by geriatricians, by allied professionals who should develop a clear argument base to convince not only supranational institutions, but also national and subnational institutions to develop these specific healthy aging programs, because in my view, this need is not clear for all people. So this is the way I see it. No, it's not clear for all people who is already working from different perspectives, attending the needs of all people. And the responsibility is on our side, not on their side, I think.
¿De Armando? Si alguien quiere hacer una pregunta en castellano, la traducimos. Si yo me trabo, me ayuda alguien. O sea que sentiros libres de preguntar.
Hello, thank you all for your presentations. My question is, I think one of the main barriers that all of these health programs face is budget allocation. Because if all of these health programs are not properly funded, it's not possible to make them a reality. And my question is, how can we make a difference so that people that manage money understand that this is a very necessary health program to implement? Because I think that there is already enough evidence that the benefits surpasses the cost of all these health programs.
Who wants to respond? Yep. Okay, you can.
Okay. For example, integrated care for older people, ICOP approach. Now we are developing how to implement this ICOP. I showed you in the slide for to way forward. So there is different approaches to make it work. Which one is that you need to listen who is implementing, like primary care doctors and social workers, because in the end, they are the one who use these guidelines or these systems. And also, we need to show the policymakers how much it costs and what is the real benefit as a population. So for that, we are planning to pilot this ICOP approach from the small scale. There are many countries who are interested, but we cannot do it as a country for the first time. So we collaborate with researchers and universities and municipalities in different countries to see what is a feasible thing to do. And when we pilot, we know what is not real. Like we cannot do these things in special settings. And then we can show how much it costs and what is the outcome by piloting. So that is, I think, the best way to convince policymakers to budget this program.
Profesor Avizanda.
Maybe I would like only to say that budget is important, of course, it's important. And when we plan and approve one program, one specific strategy, in general, we always specify like some kind of budget. But in countries like Spain, we have a very, very decentralized national health system, and sometimes budget is important, but also it's very important to coordinate all the efforts and all the institutions and all of the administrations, because in many times we do something pretty similar in different levels, at national level, at regional level, and at community, at a local level. And at the same time, and we think about sectors, sometimes we design pretty similar policies in the Department of Health and Social Services and sports, why not? And that means that if we make an effort and we work together in an interdepartment way, I think we are going to give an added value for these programs too.
Thank you for your presentations. I absolutely agree with Professor Mañas that we think that WHO Europe and the Health Ministry of Spain are going slower than we would like in the aging aspect. However, I think that in the last 10 years, some work and good work has done regarding healthy lifestyles. And most of the recommendations of WHO and Health Ministry are related to healthy lifestyles. However, I think that very little work has been done regarding healthcare systems related to older adults. And we all know that older adults are responsible of more than 50% of the global costs of our healthcare system. So I think that it's time just now to begin to work in this issue, because our hospitals are the same than 20 years ago. The professionals that work in medicine are the same than 20 years ago. Human resources have not changed so much, and our population is getting really very, very, very old. So, Elena and the rest of the table, please. What do you think we should do to begin working in changing our healthcare system to adapt it to his most important user, that is the older adult? Thank you, and sorry for the question.
If I had in English. No, it's like, I think this is a question of all of us, not only related to politicians. I think now it's time to put on the agenda, of course, the healthy aging and the aging issue, and of course the need of taking into account this orientation when we talk about health, our health system. But as I've already explained, we have a very decentralized national health system, and that means that, of course, we have to lead and we have to propose, but all of us have to work together in order to come to an agreement, because the reality is here. The reality is here, and of course we already know. But with your help, with the help of the professionals, I think we would be able to put in a higher priority this issue. I'm completely sure.
The last question, Ainhoa. Espera.
Thank you for your presentations. Thank you for your presentations. I would also like to make a loud thought about all of this we are talking about, and it's that integrated care and multi-component approach that is what geriatrics and geriatricians talk about all the time. Put the patient in the center, always as a great idea, but we might put the patient in the center now and make a global strategy of older people empowerment so that they can demand adequate health system approach to their problems. And the concept of intrinsic capacity and functional ability are very well, very intuitive and very easy to understand for older people, and very every older people would like to achieve this, their maximum capacity if we explain what it is. So we explain it to them and we make a global strategy of empowerment of older people. They might be, in order to demand this to the governments or to the local and global politicians. So that might be also.
Sorry, what is the question?
No, it's not a question. It's that we might put also some kind of money on global older people empowerment.
Okay, thank you very much.
Thank you.
Yuka wants to say you anything?
For care in community settings, for example, when I was working as a primary care physician, I see 100 patients per day. 100 patients. So where do I have the time to measure intrinsic capacity?
I'm really sorry, but I have to leave right now. I have to fly to another city. That's why I'm very, very sorry, because I really would like to finish the round table with you, but the taxi is waiting for me right now.
Thank you very much, Elena. Thank you very much for your time and your presentation.
Perdón. Perdón, tenemos un descanso ahora hasta las 6:30, ¿vale? Tenéis un café.
Deja terminar a Yuka.
Perdón.
Espera. Finish, Yuka. It's okay. Okay, so we finish the...